Trail. Any questions from Trail?
Yeah, actually, I work in telehealth, and I was just curious whether in what happened down in Vancouver Island, if telehealth could be used in assessing the patient for this.
Yeah, so we have set up a telestroke service, which is presently in a sort of preliminary phase to Nanaimo and Cowichan District. And although it is ostensibly set up to manage acute stroke in the setting of TPA, it's actually a valuable resource to use for TIA. And as I said at the beginning, because ACVS doesn't come in the front door with with TIA or stroke on its T-shirt, we maybe get involved with an acute event and it gets better, and we go on to sort of manage the second part of it, which is the relapse intervention part, as opposed to the revascularization part. So I think there's a big role for TIA, for telehealth, and there's a second a part of this telestroke project happening out of Vancouver Coastal coming up in the new year as well.
I wasn't sure, did we miss Kamloops? Was there anybody from Kamloops that wanted to ask a question? Okay, so we're moving on to Houston. Anybody in Houston have a query?
No, we're fine.
Smithers.
What percentage of your people come in by ambulance, and what percentage of your people come in by other method?
Well, for the rapid assessment unit, they are referred on from the emergency room. So nobody comes to our unit by ambulance. They've all had their first port of call at the GP's office or the emergency room. So for time's sake, I'd kind of cut some of those parts out. So when we talk about stroke, can you turn your
mute off?
Turn your mute
on, please.
It's reverberating.
Yes.
So when you talk about stroke coming into the emergency room, the proportion coming by ambulance, I'm not sure what that is right now, actually. It's much higher for intracerebral hemorrhage because they tend to present with a more acute and devastating picture. So it's unfortunate that the ambulance typically brings in the patient that we can't do something about because we don't thrombolyse them.
Does that answer your question?
Thank you.
I have a further question. How many TIAs come not from emergency but from physician office type of things, visits?
Our ratio is 50-50. Fraser's ratio is 80-20 or less. That really represents the amount of time that we've been around, and as GPs have got the hang of us being available, are using our resources more. The hit rate from general practice is not as good as from the emergency room, so we tend to get more mimics, and that may be because general practice has found a quick way to get a neurological consult. But at any rate, we do get 50% from general practice.
Thank you.
Surrey. We have a large contingent in Surrey.
Right now we have two people with questions. The first question I had was, in your stroke clinic, what disciplines see the patient? Do you know of any pharmacists in the stroke clinic? And do your patients come back for follow-up risk modification?
Those are great questions. We should have a pharmacist given the amount of drugs that we have in the clinic and the amount that we give out. So we smother people in medications, and we do it in a very ballistic fashion. And based on the evidence that statins reduce stroke recurrence regardless of the LDL level, and that they reduce stroke recurrence regardless of whether they're normotensive or hypertensive. And these patients are typically 2 days out, so my earlier comments about dropping the pressure with collateralization becomes less of an issue as you move out. And so, and we also put them on dual antiplatelets for a month and then just on a single antiplatelet. And when the patients require anticoagulation, we swing them into a DVT clinic so that they are treated immediately with low molecular weight heparin and Coumadin. And there is a pharmacist who works there who helps us get that all done. In terms of the long-term risk modification and sort of fine-tuning the drugs that don't sit well, the way that BC has funded the sort of chronic disease management, there is a real incentive for family practice now to take on these cases and look after their long-term risk management. So we're hoping to be fitting increasingly into that. The other disciplines in the rapid assessment unit is we have stroke nurses and we have an MOA. And because we're not doing any of the rehab at this point, these people are by and large walking in. They don't have residual deficit. On occasion, when we get somebody with residual deficit, we will swing them to our outpatient rehab facility.